Yes, management and of snake bite poisoning. Factors contributing to severity and outcome in snake bite is the first point that is given there. It is given as a tabular column. So how not all the snake bites are lethal or ending in danger to the life. So the size of the victim, the comorbidity, which part of the body has been bitten, and whether patient has exerted himself because it will make the poison get absorbed faster, and then individual sensitivity by characteristics, species of the particular snake, secondary infection, what treatment was given. So these are all the points which will lead to, and also the time of snake bite, whether it happened in day or night. Because if it is in night, first of all, you do not know whether it is snake bite or not in the darkness. Then you may delay the treatment or shifting the patient. Whereas in daytime, it may be clearly visible. That also plays an important point. So these factors are the things which decide. So first thing, what you have to do in the stages of management, more than the clinical symptoms you write about, it requires, these are all the steps which are recommended by the WHO. First aid treatment, transport to the hospital, rapid clinical assessment, station, investigation, clinical assessment, antivenom treatment, observing the response, deciding whether to repeat the dose of an antivenom, support or ancillary treatment, treatment of bitten part, follow-up, rehabilitation. These are all the steps or stages in the management as given by the WHO, World Health Organization. So I think you can go on to present like this itself. So what are the guidelines for the first aid treatment at the community or village level? Usually you find it more often happening in the rural areas because of the dense forestation and the cool nature where the snakes can hide rather than in the urban areas. So check history of snake bite and look for obvious evidence of bite. Not all the time you will find the puncture marks. Sometimes in the great bite there are no local marks which may need a magnifying lens to see the pinhead size bleeding spot and the surrounding rash. This is all the thing. So first thing we must know whether the person has really been bitten by the snake or not. Then reassure the patient. These are all the first aid steps. And immobilize the limb and do not block the blood supply by applying a tourniquet. So this is how you immobilize and milk by mouth so that patient can, if necessary, given any. Sometimes they may vomit after the antivenom treatment, or they may require mild anesthesia to do some procedures. So it is better to not like the common practice to give a aerated drink or make the patient drink a lot of water. That should not be first of all done. And don't apply any all the movies you would have seen applying some leaves. The hero will bring it and crush it and put the drops on the bitten area. All that is not to be done. And ship the victim immediately to the hospital. Arrange for transport as quickly as possible, whatever be the mode, and don't allow the victim to do the driving or move himself, because that will cause the absorption of venom much more faster. And inform the doctor of any symptoms or progress of swelling or ptosis and new symptoms that should be conveyed to the doctor in the hospital. And remove all the jewelry, because that limb where it has been bitten, normally you get bitten only in the periphery part of the body. Very rarely it will be in the trunk or in the back. So those area, the particular limb where the bite has happened, must remove all the constricting structures like shoes or rings, watches at the earliest, so that any there is one condition as she mentioned is the progressive painful swelling is one of the manifestations. In that case, it will be very difficult to remove such articles from the body. And if there is already a blister formation, do not try to open it out. Whereas in burns, if you get a first degree burn and you get a blister, you try to puncture that and let out that fluid. But here it should not be done. And no time should be wasted in attempting to kill or capture the snake at the site of snake bite. And if the snake already has been killed, then it can be taken with the patient for identification of what type of snake it has been dead. And do not handle the snake even if it is dead, because sometimes even a dead snake can bite. And if nowadays everybody has a mobile phone, so you can take a picture. If you are afraid to carry the snake, you can take a picture and show it to the medical personnel. Do not wash the wound or interfere with the bite wound. This may introduce infection or increase absorption of the venom or increase the bleeding. So don't meddle with that. Do not apply any anti-snake venom if it is available at the wound site. Even after he comes to the hospital, some paramedical people may try to apply the anti-snake venom at the site of the wound. That should not be done. Now, after this first initial first aid, how do you transport the patient? Give prior intimation to the receiving center with whatever communication facilities are available. If you are transporting the patient by ambulance, it should have a transport ventilator, because in neurotoxic cobra bites, patient may rapidly go into neurogenic weakness, lose muscle power, become hypoxic by hypoventilating. So you may need to ventilate the patient en route itself. So it should be equipped with a transport on ventilator, or at least an ambu bag should be available. And if you, when you contact the medical center where you are transporting, ask them whether they have the anti-snake venom. If they don't have that, try to find out where it is available and shift the patient straight to that center instead of wasting time by taking him to one place and then transporting to another. And transfer to a higher health facility wherever a tertiary care hospital is present. Better to take them straight there. And even if you are initially, if you take them to a center where anti-snake venom is available, first administer anti-snake venom. And if further complication happens and you want to shift him to a higher center, do it after the snake venom infusion. And during transfer, continue life supporting measures like inserting an nasogastric tube, provide clear airway. So these are basic things which you have to take care of, and document all the findings that has been done right from the beginning, and mention the clinical status if you are referring to a hair center. And treatment initially, when it is in the dispensary or hospital, look at the signs and symptoms of snake bite. So four main categories. One is progressive weakness, second is bleeding, third is myotoxic, and fourth is painful progressive swelling. These are the four different ways it can clinically present. So this presentation varies with the age and size of the patient, species of the snake, number and location of bites, and quantity and toxicity of the venom. So it will not be the same in all patients. So these are the factors which determine the severity. So this is the flow chart that has been given, which is easy to remember. So if suspected snake bite, if you find the fang marks, which is a overt bite, that is very visible. History of bite, non-venomous snake is 70%, venomous snake is 30%. And even after the bite, if the patient is asymptomatic, it may be definitely non-venomous, and patient may sometimes be afraid and anxious. Because of that, he may have palpitation and tachycardia. And if the amount of venom that has gone into the body is very, very low, then this is called a dry bite. So either it is a bite by a non-poisonous snake, or it is a bite by a poisonous snake in which very small quantity of venom has gone into the body, then it is called a dry bite, which will produce only these symptoms of anxiety, palpitation. Whereas when it is a venomous snake and patient is has become symptomatic, then you may have these four presentations: progressive painful swelling, neuroparalysis, vasculotoxic or bleeding, myotoxic. So these are the four presentations that you have. And because fang marks are not there, as I told you, in trach bite, it is called occult bite. So patient does not know, or he has not felt any pain, but he may start with a neuroparalytic symptom of with no local signs, severe abdominal pain, vomiting, all these things may be there. Then immediately treat them with anti-snake venom and atropine and neostigmine and ventilation. I think this has to be mentioned in your included in your answer. So symptomatic, these are the four types, and viper produces progressive painful swelling, cobra produces neuroparalysis, Russell's viper and saw-scale viper produce vasculotoxic, and flat-tailed or sneeze snake produces musculotoxic. So these are all the presentations in various types of the four types. And even though present as a predominant manifestation, there may be overlap of symptoms as well. And anti-snake venom is indicated in rapidly developing swelling only. Purely localized swelling or without bite marks, there is no need for giving anti-snake venom in this progressive painful, that is viper bites. For reaction to anti-snake venom dose, adrenaline should be given in 0.5 milligram IM dose, and specific AST for sneeze snake or pit viper is not available, and atropine 0.6 with neostigmine can be given in IV stat for repeated neostigmine with atropine for this neuroparalytic or the crate bites, which will restore the muscle tone. The patients many times present with non-specific symptoms, and this is again the same way it is presented. And what is dry bite? Again, I have just elaborated it. Symptomatic patients, neuroparalytic progressive weakness, which is the elapid envenomation, and it occurs within 30 minutes to 6 hours, as you rightly mentioned, and it is usually following the cobra bite. And it may sometimes occur after 6 to 24 hours after a crate bite also. And crate bite again, you won't get any fang marks. So it is usually a occult bite. And doses in crate bite have been recorded even after 36 hours. So observation is very important. And these are the 5Ds and 2Ps we mentioned. Patient who develops neuroparalytic or progressive weakness will initially have dyspnea, dysphonia, dysarthria, diplopia, and dysphagia, because their neuromuscular activity is reduced and they may have ptosis and paralysis. So this is how the phases of a patient with neuromuscular progressive weakness will happen. You can see he is not able to open the eyes. He is trying to open, but only the eyebrows are going up. So that shows the amount of weakness in the orbicularis oculi. And signs of impending respiratory failure may be there, and deep tendon reflexes are diminished, and head lag is there. If you ask the patient to lift the head, he will not be able to do it off the pillow. Just like our testing our neuromuscular ability after reversal, if you ask him to do the head elevation, he will not be able to do that. And you can use the bedside lung function test like single breath count. Ask him to count the numbers. If he is able to count more than 30, it is normal. Breath holding more than 45 seconds is good. Ability to complete one sentence in one breath, that is also indicative of good muscle power. If he is not able to do all these things, you can identify that muscle weakness is setting in. The second type is vasculotoxic or hemorrhagic. Earlier it was called hemorrhagic snake bite features, and it is usually due to the viper. So here it is the cobra or crate. Here it is the viper. So the local manifestations, local swelling and bleeding, blistering, necrosis, and pain at the site and severe swelling, which can result in compartment syndrome or absence of peripheral pulses and hyposthesia. All these things can happen. So the gum bleeding, viper bite, bilateral conjunctival edema and chemosis, and local leg bleeding, and the it's all happening in Russell's viper bite. Yeah, so just to remember, you can see these pictures so that you can recollect if you want to write this answer. And the life-threatening complications are due to renal involvement in these cases because patients may have hemoglobinuria, hematuria, and myoglobinuria and result in acute kidney injury. So the most instead of hemorrhagic shock, they may die of renal failure mostly. The third variety is painful progressive swelling, PPS, and this is indicative of local venom toxicity. So this is supposed to be not involving the neurological or the hematological system. It is mainly a blister like this and edema like this, or the puncture marks, the fang marks may become swollen like this. And the last variety is myotoxic. It is common in snake bite. So people who go to Bali or Thailand and all those involving in sea sports, there is a chance that the snake bite can happen. And patients with muscle aches, muscle swelling, involuntary contractions of muscles, and passage of dark brown urine, and compartment syndrome, cardiac arrhythmias, and acute kidney injury due to myoglobinuria because the muscles are undergoing this problem, and the subtle neuroparalytic signs may be there. So myotoxic is also quite dangerous. And clinical situation in which snakebite victims might require urgent resuscitation, profound hypotension and shock. Actually, you have to resuscitate the cardiovascular system. They may have respiratory failure due to neurotoxic envenoming or sudden deterioration because of severe systemic venom going into the system, and cardiac arrest because of hyperkalemia. So these are all the four dangerous situations in which a snake bite victim might suddenly die. And detailed clinical assessment and species diagnosis ask the question what the victim was doing at the time of the bite. Bite marks are no use in identifying if a species is venomous or not. So you can't say whether the snake is a poisonous or a non-poisonous by looking at the bite mark, and determine the exact time of the bite, because earlier the administration of anti-snake venom, better the chances of survival and recovery. So where possible, identify the snake, which type of snake which is responsible, obtain a brief medical history, and then early clues. Snake identified as a very dangerous one, rapid early extension of local swelling, and early tender enlargement of lymph nodes, early symptoms of collapse, early spontaneous systemic bleeding, and passage of dark brown or black urine. All these things include a severe variety of inflammation. So, what Pavitra was describing at the various grades, if you write all that, it will be too long, time consuming. So, you can just mention the conditions where you can identify a severe venomous intoxication. Late onset also sometimes happen where bilateral doses appeared after a day or 1.5 days, when patient came with the complaints of only pain abdomen. So only the medical personnel will notice that the bilateral doses is there. So it looks like it is an incidental finding. Now coming to the details about anti-snake venom, it is indicated when there are signs and symptoms of envenomation with or without a history of lab test, you must administer full dose even if there is a suspicion. If the symptoms signs are proving that it may be venomous, then you have to administer full dose. There are no absolute contraindications to anti-snake venom, and in India we get only polyvalent. Monovalent is more expensive, and it has got a very short shelf life, as we said. So we have only polyvalent, which can be administered against all the 4 types of snake poisoning. And dosage, of course, as we mentioned, there are two preparations. One is a lyophilized powder, and another is a ready liquid form. And the difference between the two, she mentioned, it has got a long shelf life, whereas the liquid form has got only a shelf life of 2 years and does not require a cold chain. It can be kept in the room temperature. And only thing you require to dissolve it with the saline and reconstitute it. It may take within the 30 minutes time you have to do that. And there is no need for reconstitution if it is a liquid anti-snake venom. And it should be always given by IV route. There is no IM or local application. As a physician at the bedside, he should be always, when snake venom is being administered, responsible physician who can immediately tackle an emergency, because of anaphylaxis is sometimes very seriously can happen. So it should be not under the care of a nurse or a paramedical person. A competent physician should be available at the bedside. And if there is any sign of reaction, he should immediately intervene. And epinephrine should always be drawn and kept ready, so that even at the earliest sign of any anaphylaxis, you can immediately administer that. Take all aseptic precautions before administering, so that pyrogenic reactions are reduced. And if the biting snake is identified as a soft-tailed viper, 5 vials may be given at the starting dose as an IV infusion. Otherwise, in all cases, starting dose remains 10 vials. For neuroparalytic, 10 vials may be required, which must be given as an infusion over 30 minutes per period. And if response is not satisfactory, a second dose of again another 10 vials after 1 hour can be given. For vascular toxic, that is hemorrhagic, two regimes are there. So for neuroparalytic, straight bolus doses at intervals of 1 hour. Whereas for vascular toxic or hemorrhagic, two regimens. One is low dose infusion, where 10 ml, 10 vials for, it is all in vials. There is no milligram or units or anything like that. So it is a vial, it is a standard preparation. And 10 vials for ripe viper and 6 vials for soft-tailed viper for IV infusion, followed by 2 vials every 6 hours. This is the recommended dose. And for 3 days, you have to continue in low dose infusion. Whereas in high dose, you start with 10 vials of polyvalent venom, anti-snake venom. You will start over 30 minutes as infusion, followed by 6 vials, 6 hourly as bolus therapy till the clotting becomes normal. This is called the high dose infusion. What are the adverse reactions? Early anaphylaxis can occur within 10 minutes to 3 hours time. And pyrogenic reaction, just fever, serum sickness like thing in 1 to 2 hours. Late serum sickness reaction develop 1 to 12 hours or even after 7 days. Antivenom treatment alone cannot be relied upon to save lives if there is bulbar or respiratory paralysis. So in all cases of neurotoxic, AIM challenge test should be done. That is atropine 0.6 milligram followed by neostigmin 1.5 to be given in IV stat. Repeat dose of neostigmin 0.5 milligram with atropine every 30 minutes for 5 doses. And in children, you give a lesser dose of 0.5 milligram of atropine and 0.4 milligram of neostigmin, and repeat dose 0.1 every 30 minutes for 5 doses. So this is the fixed dose, the myopyrrolate, which we are using nowadays for reversal, that also can be used. So this helps to increase the acetylcholine level and re-establish the neuromuscular transmission, because the paralysis is mainly because of the blockage of that. And the airway support is more of a supportive measure. Chemotaxic innovation, you can rely on blood products and renal impairment. You have to treat with renal replacement therapy. So hypotension, severe reduction in HB, platelet, you can replace all that. The majority of the time, timely use of anti-snake venom will stop the bleeding in most of the cases. But only if the bleeding continues, you go for strict bed rest, screen for hematuria, hemoglobinuria, because the risk of renal involvement is very high if these things happen. Monitor urine output and volume replacement, can establish IV access, give a fluid challenge of 2 liters of isotonic saline over 1 hour or until jugular venous pressure or central venous pressure rises to 8 to 10 centimeters. And observe the patient closely. You must stop the fluid challenge if there is any evidence of pulmonedema, which is a natural logical thinking. Renal failure and anti-snake venom is common complication contributed to intravascular species in viper, Russell's viper bite. And it will, because it causes hemolysis, uh, disseminated intravascular coagulation, or it can sometimes be direct nephrotoxicity because of or hypertension and rhabdomyolysis. These are all the causes of renal failure. And the usual indications for dialysis should be followed, and patients should be uh, put on hemodilution, hemodialysis or hemofiltration as early as possible. So renal replacement therapy, that is all the indication, just to make sure that these points you may remember even for CKD patients also. And pain and wound management and surgical aspect, pain relief is the most overlooked aspect of snake bite. People don't give that much importance to that. So paracetamol 500 to 1 gram per day, 500 milligrams to 1000 milligram, pediatric dose 10 mg per kg, or tramadol as all which she mentioned. And there is a condition called snake venom ophthalmia, where the patient complains of severe pain in the eye, and it is treated with 0.5 milligram of epinephrine, which gets relieved. And conservative treatment, when no anti-venom is available. So if the venom is not, once you give anti-snake venom, the improvement is remarkable. But if it is not available, you go for mainly all the supportive measures. And there is a respiratory failure, you must go for ventilation. And hemostatic abnormalities, you go for transfusion and management of hemorrhagic shock and myocardial damage, all these things. And of course, acute kidney injury, go for conservative treatment or dialysis. So if you classify and write like this, I think you can complete the answer within the available time, and at the same time mention all the points. So the main points you have to remember is there are 4 types of presentation. One is neurotoxic, vascular toxic, uh, myotoxic, and progressive painful swelling. These are the 4 varieties of presentation, of which the progressive painful swelling will be the most least dangerous. It will not kill in progress, but it can be easily treated with surgical removal of the dead tissues and antibiotic therapy. Uh, but all the 4 types you can give snake venom as a mainstay treatment. I think the point has to be remembered all the time.
Thank you, sir. Any questions from the students?
But I think they don't want to ask questions and waste time. Okay.
Yes, sir.
But,
Can we go to the next?